My name is Patrick Farley. I work at the University of Mississippi Medical Center. I'm presenting more cases involving CTAs and vascular abnormalities. This is a non-contrast CT of an unresponsive 62-year-old. Nothing is too interesting, but maybe I convince you the basilar artery is a little dense. And when we window it, maybe we can see a little bit of hypodensity in the pons. Everyone needs to see on the CTA that we have good enhancement of the internal carotid arteries, but no enhancement of the basilar artery. Remember, it's always harder to see what's not there in radiology. Reconstructions are very important with CTA, and the coronal better shows the large area of thrombosis in the basilar artery. The basilar tip is opacified, but the majority of the mid segment is completely thrombosed. On MR, we can see areas of infarct, an abnormal signal in the pons, which is infarcted. This is basilar artery thrombosis with brainstem infarct, and acute occlusion of the basilar artery can cause this. This is a neurointerventional emergency, and if it's not treated early, the patient will rapidly deteriorate and die. If patients have sudden and dramatic neurologic impairment, you're going to want to consider this especially strongly. Symptoms of basilar artery occlusion include sudden death and loss of consciousness. The top of the basilar syndrome has visual and oculomotor deficits, behavioral abnormalities, somnolence, hallucinations, and they may not have motor dysfunction. Proximal and mid portions of the basilar artery can cause a locked-in syndrome if there is infarction where the patient has quadriplegia with complete loss of movement but preserved consciousness. Basilar occlusion is a life-threatening event. The prognosis is terrible if untreated. So treatment is extended for basilar artery thrombosis compared to other intracranial arterial thromboses, and catheter-directed thrombolysis can open up the vessel. Mechanical embolectomy can also be used. Back to the perfusion again, cerebral blood flow on the left, cerebral blood volume in the middle, and mean transit time on the right. We can see that there is a matched defect in that left occipital region. When we look at the CT, we see that there is volume loss in that area. So what is that? That's encephalomalacia, and that can result in a matched defect too. Patient with left-sided weakness. Again, we see that we've lost our right insular ribbon, and our gray-white differentiation is a little bit decreased in that area. We do our perfusion study, and we can see that we've got a large cerebral blood flow, decreased area in the MCA territory, increased MTT, and a pretty good sized area of abnormal cerebral blood volume. On MR, we can see that the infarct correlates well with the area of cerebral blood volume abnormality. Always check the insular ribbon on the CT. This perfusion study shows decreased cerebral blood flow and increased mean transit time in the right MCA and ACA territories. Cerebral blood volume is decreased in the right ACA and somewhat in the right MCA at this level. More inferiorly, we can see decreased cerebral blood flow and increased mean transit time in the right MCA territory with a more preserved cerebral blood volume. When we look at the CTA, it's important to see what's not there, which is the normal enhancement of the right cervical internal carotid artery, which is occluded. On the MR, we can see restricted diffusion with corresponding ADC abnormality involving portions of the right middle cerebral artery territory and at the junction of the right middle and posterior cerebral arteries. That area of abnormal perfusion in the anterior cerebral artery territory corresponds to an area of encephalomalacia and gliosis, and that is from the old right ACA infarct with the occluded right internal carotid artery. They had new acute infarcts in portions of the MCA, likely due to a watershed type phenomenon. Non-contrast CT in this patient shows hyperdensity in that right suprasellar cistern and anterior to the right midbrain. We can see hemorrhage surrounding the medulla. The CTA was negative. What may that be? A benign perimesencephalic hemorrhage. Often angiography is used to confirm that there is no vascular abnormality. In recap, please remember that basilar artery thrombosis is devastating and needs to be treated as soon as possible. Remember that encephalomalacia and other intracranial abnormalities can cause perfusion abnormalities, so always correlate with your CT and MR images. And remember that benign perimesencephalic hemorrhage can be a cause of subarachnoid hemorrhage, but that this is a diagnosis of exclusion. Thank you.